Inherited disorder. Some famous people that had this disease. It's the opposite of Parkinson's disease. So tomorrow in neuro, when we're talking about the basal ganglia, well today actually, you're going to get part of it. So there's a reciprocating circuit from the substantia nigra to the caudate nucleus. You're going to encounter these things, they're deep brain structures. This is a brain stem, that's deep brain. If this neuron dies, it's Parkinson's disease. If this neuron dies, it's Huntington's. So the two diseases are linked. These are neurodegenerative disorders. Huntington's disease, the patient is a terminal disease. You're going to die within a few years. There's nothing you can do to slow it or do anything about it. The incidence of it is not high, but it's always very sad when it happens. You can see right here the caudate goes away. That's the caudate. It's gone right here. The thing about this disease here is that it gets into families, and it's a problem with a triplet repeat in the DNA. And the more generations, once the mutation occurs, the successive generations develop more of these triplets. The longer the triplets you have in the DNA, the younger the onset of symptoms. So once this gets into families, successive generations tend to have a more devastating onset of the disease. It's autosomal dominant, so if you go to the four-square inheritance pattern, you can figure out that you can have the disease, you can be if you inherit the gene, you're going to get it. The only way to not have it is to have a parent with the defect, but you inherit the non-impacted gene. So because it's autosomal dominant, you got a 3/4 chance of inheriting it, 1/4 chance of escaping it. So the odds are not good. Parkinson's disease is where the dopamine-containing neurons of the substantia nigra degenerate over time. The speed at which Parkinson's disease comes on is very variable. People can live with it for years and years and years. Other people can die very quickly. It's evident on histologic section here because dopamine, the substantia nigra, the black substance, that's where it gets its name, in a patient with dark Parkinson's disease, once you lose about 85% of these dopaminergic neurons, you start developing symptoms of Parkinson's disease. This is a motor dysfunction. Remember we were talking about the pyramidal system yesterday, the corticospinal tract pyramidal system? This system here is extrapyramidal. It's motor related. And what this does is that it inhibits a lot of motor activity. So if I remove that inhibition, then it sets off tremor. So all of these tremors that you're going to encounter, that's how they work. Ordinarily, motor activity is kept fluid by the extrapyramidal input to the pyramidal system. If you remove that input, then you disinhibit and allow tremors. A cerebellar lesion, because it involves timing of movement, the tremor is usually called an intention tremor. It affects timing of movement. So if I'm going to move towards Meredith's phone, as I intend to do, the tremor gets worse. If I'm sitting still, there's no tremor. It's only during an intentional movement. That's a cerebellar lesion. A lesion here in Parkinson's disease, though, involves resting. You, right now, have an enormous amount of muscle activity going on. If you didn't, you'd be just a pool of ooze on the floor, right? So you have, even though you're not moving, you have an enormous number of muscles in your body contracting to keep you in a sitting position. Why are you able to sit there still? Because even though all of these motor neurons are firing, the reason is you have something like the Parkinson's. You have something like the substantia nigra and the caudate. What these things do is they inhibit you from sitting there with a tremor. If I give you Parkinson's disease, that's exactly what they do. They sit there with a thing called a pill rolling tremor. It's usually bilateral, involving the fingers, and it looks like they're putting a pill in their fingers and rolling it around like that. It's called a pill rolling tremor. It also, and the worse it gets, the worse the disease gets. But it's resting, it's at rest. If I go to pick up that bottle there, the tremor goes away. But as soon as I stop, it comes back. So that's the difference between this type of tremor, a resting tremor, and a cerebellar intention tremor. There are other features of Parkinson's disease. One is they have a flattened affect. Their face becomes expressionless. Look at Muhammad Ali in his later life. He had no expression on his face whatsoever for decades. They have a shuffling gait like this. They have what's called cogwheel rigidity. If I take my hand and I say, okay, I'm going to lower it, I want you to resist me. You see how it goes down smoothly? They can't control that. So what it does is it goes down like that. It comes back up like that, like the cogs on a wheel. Flattened affect, shuffling gait, pill rolling tremor, cogwheel rigidity, all symptoms of Parkinson's disease. By the way, this one right here, Huntington's chorea, what this does, it produces a horrible tremor. Just horrible tremor that affects most of the body. The odd thing is with Huntington's and Parkinson's is that when they go to sleep, tremor goes away. They can sit there and be motionless, like in a resting state, no tremor. That's interesting. Because the sleep essentially disconnects the brain from the motor activity. All right, AML, Lou Gehrig's disease, amyotrophic lateral sclerosis. Again, this is a degenerative neuromuscular disease. It's a demyelinating disease. You see the corticospinal tracts are demyelinated here. When you lose that myelin, you lose nerve function. So these patients, AML, the survival here is not good from the onset of disease. It was just in the paper here the other day. One of the football coach, where is he from? Jinx? Had retired last year. He got called back. He came back to coach the Jinx. He was winningest coach in high school in Oklahoma, has AML. Been diagnosed with AML. So, that's, when you're told you have 3 to 5 years, that's pretty devastating news. They usually die, people with Lou Gehrig's disease usually die because of, they lose their ability to swallow, they get an aspiration pneumonia, and they die. A lot of these neuromuscular diseases, that's how they die, aspiration pneumonia. Multiple sclerosis is another one, demyelinating disease. Unfortunately, it's most common in the people in the very prime of their life. It affects women much more than men. The presenting complaint most of the time is headache and a visual disturbance. which on an MRI shows up as optic neuritis. Isolated optic neuritis in a 30-year-old is multiple sclerosis. That's it. The definitive diagnosis of multiple sclerosis is when you find plaques on CT. You see the plaques right here? The plaques on a CT confirm the diagnosis of multiple sclerosis. These folks, they usually are confined to a wheelchair, and progress to some type of problem like aspiration pneumonia. There are different types of multiple sclerosis, intermittent, remittent. There are like 10 different characterizations, not 10, maybe 5, of multiple sclerosis based on the prevalence of symptoms and the speed at which you have them. Some people might have what is clearly a multiple sclerotic event and then never have another one. Other people are dead within a year. So there's a difference, very different progression of disease that's very individual. Okay? Any questions about that?
Is it just the oligodendroglioma, or can it go to the Schwann cells as well?
I think it's both, but I'm not for sure on that. It does affect the motor horn cells. I don't know if it affects them once the axon leaves the spinal cord. So you will encounter people with MS. It's that frequent. Guillain-Barré is an interesting autoimmune response to a trigger, some type of trigger. And what it does is, it's another way to think of Guillain-Barré is ascending paralysis. They come in, they present with numbness and weakness in their lower extremities. The next day it's in their thighs. The next day it's in their pelvic girdle. As it ascends, if it gets all the way up to C4, it can affect the diaphragm and they wind up on the ventilator. It's usually a self-limiting disease and over time, over a period of days to weeks, the paralysis usually goes away in a descending fashion. So it's ascending paralysis and descending recovery. Things that can trigger Guillain-Barré, of course, are vaccines. That's always when you get your flu vaccine, that's always a question. Do you have an allergy to eggs? Have you ever had Guillain-Barré? If you've had Guillain-Barré, you don't get the flu vaccine. Another bug that's interesting is infection with Campylobacter. Campylobacter jejuni is a common summertime bacterium that causes a raging diarrhea. And it does so in communities. Like if you send a kid to a summer camp, you get diarrhea in the camp, or, it's not traveler's diarrhea, which is E. coli, it's an infection with that bug, Campylobacter. Usually there is complete recovery. I've seen this a few times in my career, or diagnosed it a few times in my career. You gotta watch out. You can't send these people home, and you gotta see how far that ascending paralysis is gonna go. Okay? Metabolic disease, inborn errors of metabolism. These things are horrible because it involves some type of genetic inheritance of an enzyme pathway. Two examples here that I give are Tay-Sachs disease and Niemann-Pick disease. These are board questions. There are a lot of other ones that you can see. You see here are all the inborn errors of metabolism. There are 50 billion of them involving just about every type of enzyme pathway. They're classified broadly into 3 categories with similar symptoms. The problem is, because these diseases result in a defect in some product, or protein, or lipid, or whatever, the precursors build up and are typically toxic to the nerves that they build up in. And they wind up, most of these people are, they have severe developmental problems. They usually die at an early age. And they typically can run in families or groups, like Tay-Sachs disease. When you hear Tay-Sachs disease, the thing you should be thinking of is Ashkenazi Jews. That's it. Okay, that's the board question. Okay. There's one that's Lesch-Nyhan syndrome, that's another one. Leschnyhan, Lesch-Nyhan syndrome is an inborn error of metabolism. These small children, in addition to severe, profound retardation, they wind up with self-mutilation. They eat their fingers, I mean, in their lips. It's just horrible disease. Lesch-Nyhan. They usually also die at an early age. If you want to see a good movie related to inborn error of metabolism, I would tell you to this weekend watch Lorenzo's Oil. Lorenzo was a kid with an inherited, you know the movie? It came out like in 1840, and Susan Sarandon and Nick Nolte, you guys know who those two people are, right? I think it was Susan Sarandon. Great movie. It's sad though, it's hardly sad, but it goes through some biochemistry in this couple's effort to try to save their child with an inborn error of metabolism. Okay. Didn't have Lesch-Nyhan syndrome, but anyway. Yes, ma'am.
So if they die early, how's it passed on? You know what I mean? Like,
These are sporadic type things. These are not, and not all of them do they die early. But they usually don't reproduce. But they are concentrated, some of them in particular populations. And again, if they're recessive traits, you pass those on without having evidence of disease itself, which is what Tay-Sachs disease is. It's a recessive trait. Some of them are sex-linked, so they only appear in boys, most of the time in boys.
Is Tay-Sachs that cat cry? Or did I make
No, that's
that up?
Cri du Chat. That's a trisomy 19. Why are you asking me stuff that's pulling out of my brain? Trisomy 19. I think, Google
See,
that.
you pulled it out.
I think it's trisomy 19. Cry of the cat. Neoplastic disease, real quick. So the top thing here, there are no focal neurologic signs that you can generalize to neoplastic disease. You don't become aware of them until they become large enough to produce a focal neurologic sign. If you have a neoplasia in the frontal lobes, the presenting complaints might be something as obtuse as food does not taste. Food has lost its taste. And the reason that would happen is because it's impinging on the olfactory tracts, and you don't perceive it as a decrease in smell. You perceive it as, since taste and smell are so intricately linked, you perceive it as food doesn't taste good anymore, or has no taste. Or if the ping pong ball sized lesion produces, Uncle Junior is just not acting normal. He's doing and saying some pretty bizarre things. So versus if you have a tumor of the meninges way in the posterior fossa or at the base of the brainstem, you can't reach it. You can't get it out. So anyway. All of them are potentially malignant, as it says here, all of the intracerebral tumors. These are different. This is different than a tumor that has metastasized to the brain. So the two that you're going to run into quite commonly are astrocytoma. Now, I'm not talking about meningiomas are probably the most common, and that's a tumor of the meninges. A tumor of the brain itself you don't have, it's very unusual to have a tumor of a neuron, because neurons don't divide. You have to have a tumor of something that's going to divide, which would be the glia. Astrocytoma is one of them. There are different, as I mentioned the other day, there are different stages of aggression of the growth of this tumor. The worst one is stage 4, which is called glioblastoma multiforme. This is the one that is rapidly growing, hard to kill, and it will usually, if you look at their average survival is 14 weeks without doing anything about it. This is the one that Dr. Bonetta's daughter-in-law died from recently.
Can you tell when it presents?
I'm sorry?
What, Amy? Oh, it says 5th and 6th. Sorry.
Okay. Again, these are types of lesions that occur in the prime of your life here, so that's what's really devastating about it. Metastatic tumors can come from anywhere, however, the majority will come from lung, since lung cancer is the most prevalent type of cancer in men and women now. You get a lot of mets to the brain. Fortunately, you usually die of the pulmonary complications of lung cancer before you die of the cerebral complications. Breast cancer is another one that goes to the lung, goes to the brain, and then down the brain. The interesting thing about the mets to the brain is they usually show up in the brain when patients start complaining of headache or maybe focal neurologic signs. You get a CT and an MRI, and this is what you get. The tumors tend to develop at the junction of the white and gray matter for some reason. Muscle diseases, there's a little bit of information about muscle diseases here and here. Myopathies is how you're going to generally characterize those. The prototype muscle disease is Duchenne-type muscular dystrophy. This is a sex-linked recessive disease, affects usually young boys. They usually die at an early age, and because it usually affects through the degeneration of the muscle, it affects the girdle muscles first. Then what you have is you have a little kid who can't get, when they go to stand up, a little kid just typically pops up. They can't stand up because they don't have any truncal musculature. They have to roll over and get up on their hands and knees and then kind of walk themselves up like that. Because it does involve these truncal muscles, they have gait disturbances. They're usually bound to a wheelchair at an early age. This is it's a devastating disease. Interesting thing about the gastroc, because of the fatty infiltration, looks like they have these Arnold Schwarzenegger gastrocs, when in fact the muscle cells are degenerated, and it's just fat that you're looking at. Again, there are a whole bunch of different types of muscular diseases. They're not neuromuscular, these are muscular diseases themselves. Myasthenia gravis is another one that's really interesting because it has a neural component to it. And here you have autoantibodies against the acetylcholine receptor. The acetylcholine receptor is at the neuromuscular junction. So the alpha motor neurons, they're going to synapse on the muscle cells using acetylcholine and acetylcholine receptors, right? You have antibodies to it, they're blocking antibodies, so they wind up with muscle weakness because of these blocking antibodies. It's most and easily apparent in the eye muscles, the blink. When you raise, blinking is what you do mostly during the day. That's the muscle that you contract most of the time during the day, blinking. So they wind up with weakness in facial expression and blinking. As a matter of fact, the test for one of the old tests for myasthenia gravis was to get the patient to blink, and it wouldn't be long before they would wear out. And then you would give them some acetylcholine an acetylcholine drug, related drug, to sort of give them a little splash of acetylcholine, and whoop, there you go, it's back again, I'm good to go. It was called the Tensilon test, Tensilon, Tensilon test. Now, of course, the diaphragm is a muscle that's innervated by neuromuscular junctions, just like any other muscle of your body. The problem with myasthenia patients is they have to take medicine to keep these neuromuscular junctions open. If they don't take the medicine, they'll usually die from asphyxiation because the diaphragm can't contract. Prion disease. These are, it's an interesting thing here. Prion disease. Does anybody know what a prion disease is? Does anybody not know what a prion disease is? Prions are actually, everybody has a gene called a PRP gene. If that gene mutates, it produces an abnormal protein. That abnormal protein can replicate. And when it replicates out of control, it produces holes in your brain. It's called a spongiform encephalopathy because your brain looks like a sponge, it's full of holes. This is mad cow disease. And there are other spongiform encephalopathies, some involving humans. It's not a virus, it's not a bacteria, it's not a fungus, it's a protein. It's a self-replicating protein which defies the concept of replication, because replication requires DNA or RNA. This is an example where it's the protein replicating. That's truly fascinating to me. Here's a little information about it here. The Nobel Prize winner, Nobel Prize awarded for the discovery of these things. Francis Crick was one of the two guys, Watson and Crick were the two guys that showed the formula for the double-stranded DNA. Well, one of Crick's postulates was that everything had to derive from DNA. Turns out that was wrong because of two things. One is prion disease, the other is retroviruses don't adhere to this dogma of replication. But anyway, there are two other diseases that where you see these holes in the cerebrum. One is a disease in sheep called scrappy, and the other disease is in humans called Creutzfeldt-Jakob disease. Hang on a second, it's spelled out later on, you don't have to write it down. CJD is what the disease is. It's a type of spongiform encephalopathy in humans. This is what a prion is, okay? You normally have PRP because it serves a function in your nervous system. It's only when it mutates and misfolds does it become self-replicating. The thing here about prion disease is there's the holes in the CNS, is it produces this profound dementia, motor disturbances, and death at a pretty rapid rate, usually from, again, the swallowing mechanisms and aspiration pneumonia. You don't want to get CJD. Here's a micrograph showing all the holes in the cerebral cortex. Not a good thing. Now, the problem with this is that it is transmissible. This is not, there are two ways to get a spongiform encephalopathy. One is to inherit it. The other is to get it. And you can get it by eating this misfolded prion. The simple act of eating it can cause you to get this disease. In addition to eating it, which occurred, this is so small here I can barely see it. Kuru. If you happen to be a cannibal living in New Guinea and you ate the brains of the people that the tribe next door, you're eating prions and you wind up with your own prion disease and then you get Kuru. Do a YouTube video of Kuru. This is a practice, of course, the folks in New Guinea, they quit eating each other, eating each other's brains, so they don't do this anymore, but they have these old videos from like the 30s of these people with these neuromuscular diseases, the Kuru from eating brains. Yes, Blair, that occurs. She's got to look up, it's worse than beef jerky. Okay. You might have known a few years ago, if you were a deer hunter, that these spongiform encephalopathies were occurring in the deer of Colorado and up in northern states. And there was a thing going out that don't eat, you shouldn't really eat the deer, especially the brains of the deer, because of possible transmission. Anybody hunter remember this? Yeah. So it's kind of gone by the wayside now, but this was present in the deer population before. People who ate some contaminated mad cow type food, they wound up with spongiform encephalopathy. Also, people who underwent neurosurgery, getting dural grafts or using instruments that had previously been used in a neurosurgery, they wound up with CJD right here. That's why all neurosurgical instruments now are disposable. The problem with this little bastard is that nothing kills it. You can't, there's no antiseptic that kills it, heat doesn't kill it, autoclaving doesn't kill it, UV light, nothing kills this thing. It's a protein, but it's not living. Interesting. You can denature it, that's the only way to get rid of it. But you typically don't do that when you're sterilizing. Okay, CJD here, there are different types of CJD. There's iatrogenic, it's just sporadic variant, you can read those. One type of inherited encephalopathy is fatal familial insomnia. This is go do a YouTube video on this. These people, they develop an encephalopathy. Again, it's at a pretty young age. It progresses very rapidly, and they cannot sleep. They are unable to go to sleep because it's interrupted neural circuits in their brain. They cannot go to sleep. They usually die a few days. You can only go a few days without sleep before you will die. It's like 5 days or so. And once this sets in, you will die. And there are few dozen families in the world who have this gene defect that pass it on to their offspring. It's a horrible, horrible disease. You can YouTube image this to see what it looks like.
Can you make them go to sleep?
No, there's nothing, you cannot give them Demerol, you can't knock them out. There's nothing you can do to put them to sleep. You can quiet their CNS, but they are awake, and they will die. That's why it's called fatal. It's not called near fatal, it's fatal. You will die. All right. See, we got through all of that in 1 hour and 40 minutes. What an amazing thing. Are you ready to start the neuro, or you want to take a break?
Right.
Great.